Thanks, Jeremy. Thank you. So good afternoon, everyone. I'm going to be talking, as Jeremy mentioned, on bone and joint infections. So to review and what's new, it's an interesting topic. And like Jeremy said, there's been a spate of new evidence in the last decade or decade and a half. So I'll take it away. So just an outline for the talk. I'll give a brief introduction as to the topic. Because it's a really vast topic, I'm going to focus on predominantly osteomyelitis, but we'll sort of touch on prosthetic joint infections and a couple of other things within the spectrum. Brief classifications that are used, biofilm, which really underpins why this is such a tough infection to treat, some of the evolving diagnostic modalities, and then a brief discussion on some of the history of management, and then challenging some of the dogma in terms of what we do and how we do it. So firstly, an introduction, the definition of osteomyelitis. It's any infection which involves bone, and that's with a spectrum from something as simple as an osteitis, cortical involvement, to osteomyelitis, which by definition involves the bone marrow cavity. And it's characterized by local inflammation, bony necrosis, and the formation of an involucrum and sequestrum. And what these are essentially are walled off areas of necrosis that become the nidus for infection, often surrounded by sclerotic bone. And then you've got this necrotic bone within, which becomes infected and really becomes a nidus for infection and biofilm. It's a disease of antiquity affecting all vertebrates. This is from the prehistoric times. I mean, there's fossilized evidence of dinosaurs. This is a sauropod with vertebral osteomyelitis. We know in ancient Egypt, there was many of the mummies have been found to have had Pox disease or TB osteomyelitis. So a really ubiquitous disease entity in all vertebrates. It remains one of the most difficult to treat infectious diseases, and their significant morbidity really affects the quality of life and at times mortality. Treatment is multidisciplinary. You need input in terms of antimicrobials, debridement, plus minus removal of devices or hardware, and then often you need soft tissue coverage. You even may need plastics to get involved at the end of it all. And despite being a common reason for an ID consult in a complex disease, it's actually relatively understudied. If you do a simple PubMed search for the common cold, filtering it by randomized trials in the last half decade or in the last half century or so, you get 646 results. You do the same thing for osteomyelitis, and this is in the last 50 years or so, 140 results. So it's a relatively understudied entity, which is one of the reasons why we do sometimes struggle in terms of knowing exactly what to do and the strength of the evidence base for what we do. So in terms of some classifications, there's two I'm going to discuss, probably the two most commonly used. The first one is the Cioni and Marder osteomyelitis staging system. And here it's basically a description based on the anatomical location. Medullary stage 1 would be medullary osteomyelitis. This is like your native vertebral osteomyelitis case, where it's purely medullary cavity, often hematogenous in nature, and there's not really a role for surgical management per se. Stage 2 would be superficial osteomyelitis. This is where it's involving the cortex and is potentially usually with a contiguous skin or soft tissue infection, but usually debridable without compromising stability. Localized osteomyelitis, this is where it's slightly deeper. You're dealing with full thickness or cortical sequestration, and it can be removed surgically, although obviously you need to take out a bigger segment of bone. And then diffuse osteomyelitis, where essentially you need to remove large segments of bone, and this compromises bony stability. And then there's the physiological class, looking at the host. And in terms of host, it could be a normal host, or it could be a scenario where you have systemic compromise or local compromise related to, for example, chronic lymphedema or venous stasis or arterial blood supply, scarring, etc. So just to go through those again, it often bears weight in terms of the treatment options. So type 1 would be medullary, where you just have medullary cavity involvement, and that can often be treated with antimicrobials alone. Superficial osteomyelitis, where superficial debridement, tissue debridement is what's needed. It's type 3, where it's a localized osteomyelitis, but deeper, but doesn't compromise stability. And type 4, where without radical debridement, which is going to require implantation of hardware, you can't maintain stability. The Waldvogel classification is a bit more, I find a bit more applicable in terms of understanding the pathophysiology of the disease. And it relates more to the mechanism of bony infection. And this sort of dictates more of how it made more sense to me in terms of how to approach it. So firstly, hematogenous, and this is more common in children, although we do see it in adults with bacteremia, staphylococcal bacteremia, etc. And this is where it's hematogenous seeding to bone with resultant bony infection. Then there's contiguous, and this is more commonly what we see in adults. And this is where you've got bacterial inoculation from an adjacent focus. So this is post-traumatic, an open fracture. Patient has had instrumentation of the bone for whatever reason, prosthetic joint replacement, and that's more commonly what we see in adults, and often associates with chronicity, and can also associate with hardware. And then associated with vascular insufficiency, which is put into a separate category, and this comprises scenarios where wound healing or healing of the bone is compromised, and delivery of antimicrobials may well be compromised. And this is, for example, patients with peripheral vascular disease or diabetic foot associated with osteomyelitis. The duration of infection is also used to stratify whether it's acute or chronic. And the truth is, this is much more of a spectrum than a strict criteria of what would be acute and chronic. And obviously there's everything in between, but chronic osteomyelitis would be where you have large areas of ischemia and the development of sequestrum formation, with that potential for chronicity and difficulty to eradicate. In terms of the microbiology, so again, more than 50% of cases are staphylococcal species, so Staph aureus being probably the vast majority, and then when you have hardware-associated infections, coagulase negative staphylococci. Occasionally, less than 25%, you'll see a number of other gram-positive and gram-negative organisms, some of which can elude biofilm, for example, Pseudomonas, and then occasionally anaerobic infections and mycobacterium TB, which again is slightly more prevalent in our setting. And then really the rare stuff that you don't see often, fungal infections, brucella, assuming that the epidemiology would fit. Those are where those would be considered, but comprising less than 5% of cases. So moving on to the role of biofilm. So this really underpins the difficulty in treating this infection. So it warrants a brief discussion. So a highly organized community of microorganisms, which is adherent to the surface and embedded within an extracellular matrix of peptidoglycans. And many organisms can produce biofilm that we know, well-known pathogens like Staph aureus and Pseudomonas, but it also is the reason why several non-virulent organisms like coagulase negative staph, or even Cutibacterium, previously Propion bacterium, which really are not pathogens in their own right in the absence of hardware on which they can attach and form biofilm. But this is the reason that these avirulent organisms can indeed cause infection. It's prevalent in the environment. Everywhere you look, you walk on slippery rocks across a lake or across a riverbed, the gunk in the bottom of your drain, that's all biofilm. And few organisms are required to establish the presence of a biofilm, less than 100 in the laboratory setting, and it develops fairly fast after implantation of a device. The cells will adhere, they'll signal and elaborate this matrix of slime, and that extracellular matrix protects and nourishes the organisms. Organisms live within the biofilm, they replicate slowly and essentially can be divided into two subtypes of organism. They can be sessile, sort of within the biofilm itself, and then planktonic, occasionally making their way out and potentially seeding elsewhere or growing the biofilm size. And this has major implications for therapy and diagnostics. Firstly, immune evasion. Within the biofilm, they can evade many components of the host immune response. Then antimicrobial penetrance through that thick peptidoglycan layer is compromised. The efficacy of antimicrobials, especially given that many of these sessile organisms are within a stationary growth phase as opposed to a replicating phase, and many antibiotics work better when you have replicating bacteria as opposed to dormant or stationary bacteria. And the same applies to culture, where sometimes these organisms are not as easily culturable because they are not within the replicator phase or growth phase, and they are within a stationary phase of their growth cycle. Now, biofilm-associated infections are not new. Again, from the head to the toes, we know that there are many areas where they can affect. Common examples include dental infections, cystic fibrosis or bronchiectatic lungs, endocarditis, kidney stones, urinary tract infections, and again, in this scenario, osteomyelitis. So over time, portions of infected bone become necrotic. Most commonly, the dead bone is resorbed, but occasionally sclerotic living bone will encase the dead bone, and this forms this involucrum and sequestrum that contains the infection and often prevents host immune response and antimicrobial penetration. And the new bone forms, leading to further sclerosis and periosteal thickening, and this dead bone will serve as a reservoir in the long term for persistent and recurrent infection, and that may well be decades after the initial episode. And in the picture on the bottom right, it's a CT scan of a patient with recurrent osteomyelitis, and you can see the dense sclerotic bone encasing this area of sequestrum of necrotic dead bone, and functionally can be thought of in a sense like an abscess. So treatment of biofilm is difficult. Firstly, obviously, MIC, as we understand it, antimicrobial susceptibilities, are defined by non-biofilm infections. There is the potential to measure the mean biofilm eradication concentration, which is often thousandfold more than the MIC. There are formal assays designed to actually measure this, essentially where you'll allow biofilm to develop, and then using a sort of broth dilution technique, sonicate the pegs, allow dispersion of the biofilm bacteria back into the solution, and incubate and read where it grows. There's the potential for resistance, especially given that you may well develop subtherapeutic levels of antibiotics within the biofilm, which may promote resistance. And maturity matters. The longer you leave it, the harder it is to eradicate. Now, we know that there are so-called biofilm active antimicrobials and aminoglycosides, fluoroquinolones and rifampicin are some examples of antibiotics which classically are associated with better response for biofilm treatment, and those become an option. And then obviously alternative strategies would be needed to definitively remove a biofilm, and that includes physical removal in any which way, synergistic antibiotics with biofilm, sort of biofilm activity, and potentially even local antimicrobial therapy to achieve the concentrations you may well want or need. So in terms of diagnostics, for osteomyelitis, obviously you sometimes need a high index of suspicion. There are times when it's incredibly obvious. For example, here, there's a necrotic toe in a patient with peripheral vascular disease, some diabetes. And then there's times where you may have just a diabetic ulcer. Probe to bone may or may not be positive, but you can't definitively say from the picture itself whether there is or isn't osteomyelitis. And so the primary diagnostic modalities are imaging and then biopsy for microbiology and histology, and there's a limited role for biomarkers or inflammatory markers. Now, the important thing is that radiology evolves over time, so you need to consider serial imaging for suspected subacute and chronic infections. And plain films, while they're often the first line, they have a poor sensitivity because it takes 3 or more weeks for bone to really remodel in a way that can be visible on a plain film radiograph. So MRI is the first line recommended imaging by most guidelines. It's the easiest way to detect early osteomyelitis, and the earliest sign is often bone marrow edema, although there are a number of non-infectious etiologies which can cause bone marrow edema. Problem is you can't use it as a test of cure because the post-inflammatory change often looks worse and doesn't necessarily get that much better in the long term. Other options include nuclear medicine modalities, so bone scan is sensitive but poorly specific, and a radio-labeled white cell scan is better, but it's not always available. In scenarios when MRI is not feasible due to access or patient having contraindications, CT often best combined with nuclear imaging as an alternative. So just some of the pros and cons for radiology. So ultrasound, not really useful, may be useful to detect the soft tissue component, but not useful to visualize bone because you can't see bone on sonar essentially. CT scan is useful for biopsying and for diagnosis, but it has a low diagnostic accuracy. And obviously there's the component of ionizing radiation exposure. And then MRI, which has the best diagnostic performance, allows you to visualize the surrounding soft tissue to see if there's associated soft tissue or abscess components, but there can be false positivity. Just 1 or 2 examples of the pitfalls of MRI. So if you look on the far left, this is purely degenerative disease. It's a horrendous looking MRI. This is a patient with severe degenerative spine osteoarthritis, essentially, with osteophytes, and there's a little bit of, they've herniated a disc, and there's compression and a small amount of fracturing, but there's actually no infection on this, despite there being some bone marrow edema. And then in the next one, just an example of a patient who had osteomyelitis, sort of L4, L5, with an associated abscess in front of it, an extradural abscess, and it looks worse at the end of treatment. You see resolution of the abscess, but it actually looks worse despite actually having biopsy and culture-proven resolution of the infection from a clinical and laboratory standpoint. In terms of nuclear medicine, so again, bone scan has a high sensitivity, and the main utility is we have a slightly low index of suspicion as a rule-out test, but more useful is certainly a white cell scan, which is both sensitive and specific. And this can be used especially where there's metallic implants, which may cause major artifacts in CT scan in scenarios where you were unable to MRI. And then PET scans also useful, but as we know, they can't distinguish between inflammation and infection. Moving on to tissue-based diagnostics, and this is the other major prong in terms of making a diagnosis, the gold standard is a biopsy with both positive culture and histology. And both of those are important, and I'll discuss why. So firstly, biopsy culture can be difficult to interpret. Obviously, there's a lot of potential for false negatives. Could be related to the patient already having received antibiotics, sampling bias, depending on the area that was actually biopsied, the presence of fastidious organisms or organisms that require specific culture media, and then organisms within biofilm, which as mentioned, may be in a stationary phase and don't want to grow on the plates. False positives, again, especially if you're doing a percutaneous sample, and this is also a major issue, for example, post-debridement, where even though you may well have control of the infection from a debridement perspective, the surgical field was dirty initially, and so in biopsy through that, there's a chance you may grow what's sort of hanging around in the surgical field, although you've debrided enough bone to have gotten source control. It's important to know that with prosthetics, I'm doing something called sonification, which essentially is putting the prosthesis in a culture media and bombards it with sound waves that essentially vibrate it. It improves the culture yield and time to positivity in hardware-associated infections. It sort of disrupts the biofilm. And this was just from one study where you can see on the far right, the images before, they basically cultured from the culture media before sonification and after sonification and looked at the plate at 24 hours. And you can see that growth is obviously significantly more post-sonification. And this is suggested in most guidelines for hardware-associated infections if the equipment is indeed available. There are times when you don't need a biopsy or you don't necessarily need microbiology from the area in question. In the presence of a supportive clinical presentation, and if you have supportive radiology, if you have a blood culture that is positive, for example, for Staph aureus or for Staph leishmaniasis, and Brucella is in fact also listed on that, although it's not that common to recover Brucella from blood, then you may not need the biopsy for, at least for native vertebral osteomyelitis. The IDSA guidelines talk about that. Swabbing overlying wounds, we know, is a terrible sample to take. It's poorly concordant with deep biopsy results. You tend to grow a zoo that may or may not be relevant. Swabs of sinus tracts in patients with chronic osteomyelitis are also poorly concordant, with the exception of Staph. So if you do send a pus swab from the sinus tract and grow Staph aureus, whether it's MSSA or MRSA, that may have clinical bearing on the likelihood of recovering that organism from a definitive biopsy. Histopathology is the other component of biopsy, and we should ideally send samples for both. Now, while it is potentially plagued with false negatives, because you get sampling bias, again, if you take an area that is not as dramatically or as affected by the infection, but there's in fact poor concordance with culture, and this actually might be useful. It's thought that pathology is potentially more useful in confirming the diagnosis and prognosticating when you have source control, especially post-debridement. And this was from one study looking at patients, this is post-transmetatarsal amputation in the diabetic foot, and they biopsied the proximal end, so residual bone. And in patients with positive culture, 21 out of 33 actually had negative histology, and this was found to be predictive of a better prognosis. So despite growing something from the sample, the fact that the histology was negative implied that likely they had debrided adequately and they were less likely to require further debridement or further amputation at 1 year. So again, doing both of them has both clinical diagnostic and prognostic significance. What about PCR or nucleic acid-based diagnostics? So again, there's a number of multiplex PCRs and commercial assays that are available. This is one picture of one of many. But obviously there are issues with specificity. It's PCR, it's very good at picking up DNA, whether the DNA is relevant, may or may not be, it may or may not be. So especially when looking at concordance rates with what actually grows from samples is only 60%. So what to do with the other 40% of organisms that are recovered, whether they represent colonization, contamination, or true pathogens, is sometimes difficult to decide. Again, 16S ribosomal PCR, or there's a move towards next generation sequencing. This is very useful in patients with, for example, culture negative disease, and in prosthetic joint infections with culture negative disease. This increases the yield of identifying an organism, which is helpful at times to decide on antibiotics, although obviously this is genotypic and not phenotypic, and so you don't get sensitivity per se. Well, there's the potential to pick up things like genetic markers of antibiotic resistance. But again, the limitations for both of these is the availability and the false positivity rate. Just something I came across that really was quite interesting or fascinating. This is something that's more on the horizon, but not really in widespread use. This was using ultrasensitive methods to pick up microbial cell-free DNA. So this is essentially looking in the patient's blood for little segments of DNA that are coming from pathogens. So you need ultra-sensitive ways of picking this up. And it's almost analogous to what's going on in the oncology sphere, where the concept of liquid biopsy, where it's really taking off and potentially will have utility. So it may well have utility in the realm of microbiology and infectious diseases. And this was one study looking at patients with prosthetic joint infection. So obviously, if you're able to pick it up in the peripheral blood, there's a good chance you could pick it up from the joint as well. But what was incredibly interesting to note was that it sort of mirrored treatment response. And one of the problems is that with osteomyelitis, we don't really have a definitive proof of cure. You can sort of follow serial markers. We've mentioned that imaging is difficult to follow. So proof of cure can be elusive. And this may well represent something in the future in terms of definitive proof of cure, whether you've eradicated the organism, but obviously still in its infancy and not yet available, at least in general. So how do we manage osteomyelitis? Well, obviously it's bone and joint infections in general, complex, nuanced, depends on the stage, the subtype. And so, I mean, there's a number of guidelines from the IDSA looking at diabetic feet, native vertebral, pediatrics, where it's often hematogenous, prosthetic joint infections. And if you look, there's no shortage of guidelines elsewhere. Unfortunately, nothing really local from South Africa. So there's a gap there. But this represents the heterogeneity of the conditions and the fact there's a lot of overlap in each of these conditions. Prosthetic joint infections, often they're anchored in the bone. There may be a bony component, and osteomyelitis can involve the joint or cannot involve the joint. It can become a septic arthritis, etc. Diabetic feet may or may not involve the bone. So again, there's a lot of overlap, and hence the need for multiple different guidelines. But the principles of management haven't really changed in the last 50 years. And this was a seminal paper by Dr. Waldvogel, whose name is attached to one of the staging systems we use, as mentioned. And this was a review that was 3 papers that appeared in the NEJM in the 1970s. And really it makes for an interesting read in terms of their approach, but not that much has changed. And he concludes essentially that the principles of management involve complete surgical debridement, prolonged therapy, 4 to 6 weeks, ideally parenteral, at a high dosage to achieve high bone levels, essentially the same tenets that apply today. But what was interesting to note is that the bulk of this was based on expert opinion and a few observational trials. So very little in the way of randomized and controlled data to inform how we manage this condition. And not that much changed in the last 50 years in terms of what we did. These principles have remained as the fundamental principles for treatment of these infections. And again, interesting that a large majority of that was based on expert opinion. So again, coming to our principles of management, surgical debridement, and this is more relevant with hardware or in chronic osteomyelitis. And obviously at this point, microbiology, sampling, taking biopsies is very important, and ideally 3 to 5 samples. Again, because of the chance of false positive cultures, false negative cultures, you sort of want a best of 3 or best of 5 to help you decide, is this truly a pathogen, especially when you're dealing with organisms like coagulase negative staph, which may or may not be commensal colonizers or contaminants. Prolonged antibiotics, ideally you hold them until cultures are sent, or you even have a culture result unless the patient is ill, classically 4 to 6 weeks. 12 weeks or more in certain scenarios like prosthetic joint infections or patients where you're unable to remove hardware and you're unlikely to actually manage to control the infection. So again, it depends on the context. And then there may or may not be a role for oral therapy historically, but we'll talk about that in detail as the talk goes on. And then the antibiotic choice, so bone penetration, the concept of bone penetration, which was brought out in that paper, the oral bioavailability of agents chosen, whether or not to add biofilm active agents. And with this approach, cure is achieved in around 60 to 90%, but the problem is what defines cure. And most research studies will use a period of 12 to 24 months, guidelines similarly, as no recurrence after that period of time. But just a word on cure, this is an interesting graph from a French study looking at 37 patients who had childhood osteomyelitis and subsequently recurred in adulthood, and recurrence was defined as osteomyelitis in the exact same anatomical area as the initial episode. And if you look at the time from the initial childhood episode to relapse in adulthood, you're looking at a period of decades, anything ranging from 1 decade to, in 2 patients, 70 to 80 years. So the concept of cure perhaps is a bit elusive because these infections can reactivate in a sense because of the pathology of the sequestrum formation and the fact that that can remain in a dormant state for a prolonged period of time. When it comes to surgical management, I'm not going to really discuss that. That's the purview predominantly of the orthopedic surgeon. So I'll leave that to them one day. Perhaps they can come on. But there is a lot of nuance. And there's a lot of research in this field as well, in terms of, especially with prosthetic joints, retention versus 1 or 2 stage debridements or removal of hardware. So again, I'll leave that for now, for another day. What I'm going to focus on management-wise is prolonged antibiotics and the antibiotic choice. So firstly, we need to know the history of antibiotic use in osteomyelitis. Maya Angelou said you can't really know where you're going until you know where you've been. And there's a really interesting paper from Open Forum in ID from 2019 that takes you through the history of antibiotic treatment of osteomyelitis. And this starts in the 40s and 50s with the sort of uptake of penicillin. And interestingly, most of the cases here were short courses for acute osteomyelitis in children with good results. Again, issues in terms of follow-up and how long cure was defined as after a couple of months versus several years. The bulk of these infections were MSSA, which at that point was not penicillinase producing, and penicillin was a good choice for Staph aureus. In the 60s and 70s, there's growing penicillin resistance in staph, and so alternative agents like tetracycline and cephalosporins are used. Anti-staphylococcal penicillins are developed around this era. And again, fair results with short course of oral therapy, again, predominantly in children. And then comes along this article I quoted from 1970 in the MEGM, which sets up the framework for current practice and advocated prolonged courses of IV antibiotics for most patients, or all patients, in addition to debridement. But as mentioned, it's coming on the backbone of the potential for oral antibiotics, shorter courses having been used in some cases. So it's interesting that that becomes the dogmatic approach to this infection. In the 80s and 90s, quinolones become quite popular. They have some effect on biofilm formation and the addition of rifampicin. In the 2010, again, observational studies with other antibiotics, clindamycin, Bactrim, coamoxiclav, cephalosporins, again, mainly observational data, but showing that essentially this leaves you the gamut of antibiotics that can be used for these infections. And then in 2019, the OVIVA trial, which really solidifies the role of oral antibiotics in osteomyelitis, and we'll discuss it in more detail. But interestingly, it concludes, as I've mentioned, that although antibiotic treatment has significantly advanced over the last 8 years, the standard approaches to treatment of the condition don't appear to have an extensive evidentiary basis. There's few historical data to support dictums such as the necessity of parenteral therapy, the universal necessity of 4 to 6 weeks duration, or the criticality of selecting antibiotics with so-called superior bone penetration. So we'll talk about bone penetration briefly. So penetrance of antibiotics into bone, or anything into bone for that matter, is dependent on vascularization of the bone. So it depends on the bone itself anatomically and the compartment of the bone, and the presence of disease, sclerosis, osteonecrosis, or sequestrum formation within that bone. It was thought that you would need high dosing strategies to ensure bone levels that would be over the MIC, but there's actually very little in the way of randomized data comparing treatments. Essentially, we've got a lot of retrospective or single drug studies and a lot of geographic differences dependent on antibiotics available in a certain location. This was a nice review of the literature, and is by Brad Spellberg, I'll mention a bit later. But this is a table from his paper looking specifically at parenteral antibiotics. And essentially what you look at is the ratio of bone to serum levels. And you can see that for the vast majority of antibiotics, they're sort of 10, 20, 30%, well below, sort of below that region in terms of the levels achieved in bone. But what's interesting is if you look at Kefzol, for example, Kefazolin, you've got multiple studies, several with the same dose, and you get different results. And so this alone speaks to the way many of these studies are done and the heterogeneity of the results, the bone, the choice of bone, the timing post administration of antibiotic, whether it was infected or healthy bone, etc. If you move on to oral drugs, and this is also very interesting, is that the serum to bone ratio is almost universally higher. And this may be a function of the fact that small molecules, more easily absorbed, can potentially get to where they need to go within the bone more easily. And again, quite interesting that your serum to bone ratio is in fact almost universally higher for oral antibiotics, as high as 100% for certain antibiotics. So there are many limits to bone penetration studies. There's an uneven distribution of antibiotics into the different compartments. The timing of sample collection relative to drug administration is not always consistent in many of the studies. Most studies, the way these were done was on normal bone. So prior to arthroplasty, you would enroll your patient, and then they would resect the femoral head and send that off, and they would do the arthroplasty on the patient. And that piece of essentially non-infected bone, which may or may not be diseased, most likely osteoarthritis or whatever contributed towards needing the arthroplasty, would be analyzed in a lab, and they would look at, depending on the knee, if it was a hip, and cancellous versus trabecular bone, cortical versus trabecular bone. Interestingly, in some studies, diseased bone was found to have higher drug levels compared to healthy bone, so maybe sort of analogous to the blood-brain barrier and meningitis, and sort of hyperemia related to inflammation, and that you may well be able to get higher levels into infected or inflamed bone. Most antibiotics exceeded the representative MICs of common bone to joint pathogens. So we're not talking about drug-resistant bugs, we're talking about MSSA with appropriate antibiotics for that, or MRSA or coagulase negative staphylococci with linezolid, for example, or vancomycin. So again, assuming you're dealing with fairly sensitive bacteria, generally, even with that limitation of the bone to serum ratio, you well surpass the MIC for the most organisms that tend to cause this infection. Interestingly, as mentioned, bone bioavailability seems to mirror oral bioavailability, and there's a number of systematic reviews which actually failed to identify any clinical difference in outcome between high and low bone penetrating antimicrobials. So there is really a question of whether this has clinical relevance, albeit very interesting. Let's talk briefly about rifampicin, because it's another component that's sort of been a bit of a backward and forward. So the original research with rifampicin being used as an adjunctive therapy for the biofilm component originates in the 1980s with an animal model where they found that adjunctive rifampicin was better for treating induced osteomyelitis in an animal model. And the same doctor, Dr. Norden, goes on to do a small trial, really small trial, essentially 18 patients with chronic osteomyelitis, and uses an anti-staphylococcal penicillin together with rifampicin. And what he found in this really small study was that 8 out of 10 in the RIF group had a favorable clinical response versus 4 out of 8 in the monotherapy, but being such a small trial, not really of statistical significance. The first significant trial, and the best research on which most of the advocacy for rifampicin in prosthetic joint infections is based, was this one done by Zimmerli in 1998, and this was specifically in orthopedic implant-related staph infections. Again, a fairly small sample size, 33 patients. Important to know that in this study, all of them received debridement and 2 weeks of lead-in IV therapy, dependent on whether it was MSSA or MRSA, flucloxacillin or vancomycin, and then ciprofloxacin, assuming that they were sensitive to ciprofloxacin for 3 to 6 months, so quite a long duration. And then the intervention group received adjunctive rifampicin from the beginning of the IV antibiotic component. 9 were ultimately excluded, so really left with quite a small sample size at the end of it all, and a cure rate of 12 out of 12 in the rifampicin group versus 7 out of 12 in the monotherapy group. So really small numbers, but meeting clinical significance or statistical significance. And so this became somewhat dogmatic that we should use rifampicin in implant-related staphylococcal infections. This was in 2018, and just to mention it, it's the ARREST trial, which looked at adjunctive rifampicin in any staphylococcal bacteremia. Now, this was a good study, big numbers, so 758 cases, and the patients were randomized to standard of care antibiotics versus adjunctive rifampicin. And the outcome was treatment failure, recurrence, or mortality. And what's important is in this trial, there was no difference in the overall primary outcome. There was a small but significant difference in recurrence rate, which favored RIF, but there was much higher adverse events related to rifampicin. But it's important to know that in this study, essentially what we're dealing with, bone and joint infections, were really poorly represented. So this was looking at bacteremia, all-cause bacteremia from staph, but in this study, osteomyelitis was included in a sort of conglomerate of deep tissue infection, which made up 24% of the total sample size, but it included vertebral osteomyelitis, epidural, intraspinal empyemas, infected intravascular thrombi, also cerebral abscesses. So really a bit of a hodgepodge, and it doesn't break down how much of each one of those comprise that 24%. So again, osteomyelitis is not necessarily a big component of this. In terms of prosthetic-associated infections, and this is generalizable to orthopedic prostheses and in fact endocarditis, prosthetic valve endocarditis, made up less than 2%. So again, it would be unable to, you can't really generalize this to bone and joint infections, be them prosthetic or other associated with staph bacteremia, but certainly in the absence of a bone and joint infection with staph bacteremia with an obvious focus prosthetic implant, then there's probably no benefit for rifampicin based on this trial. This was again a recent systematic review, that was from last year, looking at predominantly observational trials. This was in prosthetic joint infections as well, but doing a systematic review, you can see on the forest plot that overall there was a small but significant effect of rifampicin on outcomes in prosthetic joint or hardware associated infections associated with staph. So the gist of it, sorry, one last one just to mention, because it's also relevant. This was a trial also from last year, if, when, and how to use rifampicin in acute staphylococcal periprosthetic infections, but it was also an observational study. So there are two things I wanted to point out from this trial. First was that it was a positive trial, although again, it's observational. It wasn't randomized or controlled per se, but that's, while there was obviously a significant difference or improvement in, it wasn't survival, but decrease to needing further joint replacements or further surgery at 1 year, there was a difference whether it was a prosthetic knee or prosthetic hip, so the anatomical location may well matter. And then there were a couple of other interesting things that came out from this observational trial. So better outcomes were observed with clindamycin and quinolones as the paired antibiotic, and better outcomes were also associated with delayed initiation after greater than 5 days of antibiotics, and making sure the wound was already healing, the drains were out, and only then instituting rifampicin therapy. And this may be related, it's theorized in the paper to be related to reduction in bacterial load and perhaps less likely to develop resistance, because rifampicin, as we know, has quite a low barrier to developing resistance. Staph has quite a low barrier to developing resistance to rifampicin. And they were varying dosing regimens, 450, 600, in some cases higher doses, and less than 600 milligrams was more than adequate. So conventional doses, as we know, from sort of TB therapy and the like. But that informs a lot of what's done in practice, that if you are going to use rifampicin, that delaying it generally for 5 days or so, making sure that your drains are out, that would then be the ideal time to start it. So in summary, best evidence for rifampicin is in foreign body associated infections, definitely prosthetic joints, and probably generalizable to other hardware associated infections. It's suggested as an option in native valve osteomyelitis, native vertebral osteomyelitis related to staph, even in the absence of hardware. It's sort of suggested as a possible alternative of therapy together with a quinolone in native vertebral osteomyelitis in the IDSA guidelines, although they don't give a clear-cut reference for why. And I suspect it's related to the fact that we anticipate there is biofilm within those sequestri, and so there may be a role for it. But again, the evidence base for this is certainly leaves something to be desired in native bone without prosthesis infections. So adding it to a variety of antibiotic regimens certainly has been shown to improve the cure rates in animal models and a lot of retrospective studies in humans. And then again, the strongest evidence is for osteomyelitis associated with implant infections. So essentially to consider adjunctive RIF for anyone who's able to tolerate it. And if you are going to use it with a lead-in period of 5 days. And once the wound is already healing, the patient's somewhat settled. Moving on to the second last of the two topics, so oral therapy. So again, prior evidence for exclusively parenteral therapy was very limited, essentially expert opinion, and based on the concern of not achieving adequate tissue levels within the bone. There's actually a real ton of observational data advocating for oral antibiotics in osteomyelitis or prosthetic joint infections, but this was really solidified by good randomized data from the Aviva trial it was in 2019. So this was the oral versus intravenous antibiotics for bone and joint infection. A fairly big trial, 1,054 patients who were randomized to IV or oral antibiotic therapy, any bone and joint infection. So really this was quite a real world thing. It didn't matter if there was hardware or not, didn't matter the anatomical location. In fact, it didn't even matter if the debridement was undertaken or not, the surgical, whatever surgical strategy was employed. But it was this time when a bone and joint infection was presumed to need 6 weeks of antibiotics. And again, hardware was not a necessity. Exclusions, obviously, there was no oral option, or there was an alternative indication for intravenous therapy, be it gut absorption, be it perhaps endocarditis. Again, the POET trial might suggest that that's also something you could do with oral therapy, but where there was an alternative indication for IV therapy, those patients were excluded. Antibiotic selection was at the discretion of the treating infectious disease clinician, and patients were allowed a 1-week IV lead-in prior to randomization, and oral rifampicin was considered acceptable at any point in either arm. The outcome was defined as treatment failure. It was a non-inferiority study, and they did 1-year follow-up of these patients. So on the left-hand side, you can see this is sort of the randomization for IV versus oral. So a large proportion, all the patients essentially get intravenous therapy up to around day 7, and then there's drop-off to the 2 groups, intravenous and oral groups. And then in some of them, they actually transition as well. In terms of the outcome of non-inferiority, it was found to be non-inferior. Oral therapy was found to be non-inferior to parenteral therapy, and this was across all analyses, whether it was an intention to treat, whether it was per protocol. And then they did this interesting worst case sensitivity analysis, where essentially for any patient that was lost to follow-up or the data was missing, they assumed the absolute worst outcome for oral antibiotics and the best outcome for IV antibiotics to really try bias it in favor of intravenous. And even within that analysis, although it shifts to the right, it still met the non-inferiority margins. So again, no difference in treatment outcomes, treatment failure 13 and 14% in oral and IV respectively, and this was by all analyses. There was no difference really according to infection type, surgical technique, or whether there was hardware retention, the pathogen, or the antimicrobial used. Antibiotic selection was heterogeneous, but it's important to know that drug-resistant organisms were quite poorly represented in the study. So again, when dealing with a multi-drug resistant organism, perhaps one needs to be more cautious in applying the outcomes of the study. And then obviously looking at some secondary outcomes, makes sense that hospital length of stay was longer in the IV arm, line complications were longer in the IV arm, although the overall adverse effects were somewhat similar. And despite lower adherence in the oral therapy, we could see there was non-inferiority demonstrated. In terms of duration, this will be the last thing I briefly discuss. So again, 6 to 12 weeks, depending on the site, 4 to 6 weeks, potentially 6 to 12, if it's a prosthetic joint and you're retaining hardware. That was sort of the dogmatic approach. But I refer everyone to, there's a great website called Shorter is Better. Brad Spellberg, who did a lot of that review of the bony penetration of antibiotics, that nice review from earlier. He's got a great, on his website, he basically comprises, and Prof. Mendelsohn mentioned this as well in his talk recently, he comprises the randomized, so the controlled data for duration of antibiotics, advocating for short antibiotics across a spectrum of diseases. And really the website takes care of everything. It's pneumonia, it's UTIs, it's TB and drug-resistant TB, in fact, and he brings in bone and joint infections as well. So for the vast majority, essentially, a shorter course is certainly okay. So the one exception I'm just going to mention is prosthetic joint infection, where 6 versus 12 weeks, 6 weeks was found to be not non-inferior. So in a prosthetic joint infection, and this was across a somewhat heterogeneous population in terms of surgical strategy, about 40% had retention of prosthesis. So there was washout and debridement, but no removal of hardware in 40% of these patients. And there was some blowback on the study that perhaps that's not so much a real world example. And if you were going to do a 1 or 2 stage revision, you may well have found that the outcomes would have been better, and you may well have demonstrated that 6 weeks would have been non-inferior. Nevertheless, in the sort of composite, with including those 40% of patients who didn't have hardware removed, 6 weeks was not non-inferior, and so we default to 12 weeks. But in the remainder of these trials, and there's a couple of other ones I haven't put on here, vertebral osteomyelitis looking at 6 versus 12 weeks, and this is in patients with no surgical intervention. Septic arthritis, where again, classically we were taught 4, even 6 weeks. This was after drainage. 2 weeks was found to be, there was found to be no difference in recurrence. Orthopedic implant infections, and this is with removal of the implant. Again, you can get away with the shorter duration of therapy, 4 weeks potentially. There was also no difference in recurrence. Diabetic foot osteomyelitis. And here, this was interesting after debridement. In fact, 3 weeks was adequate as when compared to 6 weeks. There was no real difference in recurrence. And then the last one was acute staphylococcal prosthetic joint infection. This was in patients who had debridement, but retention of the hardware. So they didn't remove the prosthetic joint. They simply opened up, washed out, irrigated, debrided necrotic tissue. 8 weeks versus a prolonged course of 3 to 6 months, which is often what one would do if you're retaining the prosthesis, there was found to be no difference in the recurrence rate. And specifically just to stress that this is acute infection, so within sort of 6 to 12 weeks after implantation, and specifically with staph aureus. So in conclusion, osteomyelitis, bone and joint infections in general, remains understudied. So much of the current practice is based on observational data and expert opinion. And it's this very heterogeneous group of infections with a lot of overlap from one to the other. Biofilm is what defines the approach, especially in subacute and chronic infections. And this challenges both diagnostics and therapeutics. Debridement or hardware removal is integral to remove biofilm and where feasible should be undertaken. And the diagnosis of osteoarticular infection isn't always straightforward. You can get misleading radiographic studies, negative cultures, and then overlapping inflammatory or degenerative conditions. New technology is evolving, but still a limited role in real-world practice in terms of its application and defining cure. And then there's been a major evolution in antibiotic strategies over the last 10 years or so. Oral therapy is probably not inferior to IV therapy based on the Aviva trial. And for most scenarios, or many scenarios, 3 to 6 weeks of antibiotics, dependent on the infection subtype and surgical management undertaken, is probably adequate. And unfortunately, as mentioned with osteomyelitis specifically, there's often no clear-cut test of cure when dealing with chronic osteomyelitis. Thank you.
Cool, great, thank you. Thanks, Lior. For anyone, if you have any questions, just type them in the chat or else raise your hand, and we'll head off from there. Yeah, a really nice summary of a topic which requires practice, I found, to be honest, to get good at it. It sounds simple until you see some of the challenges when you deal with the clinical cases. What would you covered very nicely the differences between let's say radiological diagnoses and that. So how would you use them in clinical practice? Let's say at Barra, what would you do in terms of the osteomyelitis, either for diagnosis or follow-up?
So obviously within our environment, it becomes quite difficult to sometimes obtain gold standard diagnostics. To be honest, both the imaging and the biopsies that you need. But I would certainly push for them. And we're dealing with, for example, diabetic foot, certainly vertebral osteomyelitis, potentially periprosthetic. You would probably want to advocate for an MRI. Again, especially we're dealing with at least vertebral osteomyelitis, or things like a diabetic foot where there's a lot, where sort of visualizing it well is important. In periprosthetic infections, you can potentially use CT scan. There's often surrogate clues for periprosthetic infections, loosening of the screws or lucency around sort of the securing pins and screws can be a surrogate, and then that becomes an option. And those patients, again, the problem is a lot of the implants cause a fair amount of artifact on the study itself, so it can make it difficult. But in an ideal world, I think, especially if you're dealing with certainly vertebral, I would push for an MRI. In the absence of that, so a pragmatic approach potentially maybe for state, where MRI is sometimes quite hard to come by timelessly. CT scan and certainly a bone scan are a bit easier to come by, at least at Barra, in terms of getting those investigations within an appropriate time frame. So that would be a fallback. And again, that's an acceptable fallback in scenarios where, for example, a patient with a pacemaker or something like that who can't undergo an MRI anyway. That is what at least the IDSA guidelines talk about doing. So you could use a CT scan, ideally with a nuclear medicine scan or bone scan. Those would be options. But again, gold standard remains MRI, and that's the truth.
Yeah, so the way when I was in the US, the way they did it was very clever, actually. So the diagnosis to start with MRI is, as you said, clearly best, but it's not always required, depending on what you see, as you said. And the trick is that the X-rays take about 2 weeks. They lag by about 2 weeks. So you will see, if there's chronic osteomyelitis, you will eventually see the changes in the X-ray, but they lag. So in other words, you know, if you're starting and this has been present a long time and you do a plain film X-ray and they're present, that's fine. You don't necessarily need MRI. Different spinal, obviously, where you maybe have paraspinal collections and things which are different. But let's say a fibia, let's say, or tibula. And then what you do, so MRI for diagnosis, and then follow up every 2 weeks with an X-ray. And where that was really handy was the general duration of therapy there was about 6 weeks for osteomyelitis. And you would start to see changes, obviously, so maybe not the first one, but by the second one. And then you could track them, because by week 4, you shouldn't really have had much change from week 2. Certainly by week 6, you shouldn't have had change from week 4 if you're winning. And if you weren't winning, if you had ongoing changes on the X-rays, then you would have to do something about that, either change the antibiotic therapy or further surgical interventions or whatever. But that was pretty handy, because as you rightly said, you can't use MRI to follow up. It's way too sensitive. It just, everything lights up and it looks dismal, even when you have successful treatment. But that kind of combination of the two is a pretty powerful one. So one for diagnosis and other for follow-up, which is a nice, useful strategy, which we've used a lot over here. I see there's a comment in there. Well, people are messaging me, some privately, some on WhatsApp, and commenting on the Lautenbach procedure. Lior, don't know if you came across it in the reading.
So I came across it briefly, but I didn't read extensively about it.
It's, I think, pretty controversial. So it's very much a South African thing, and it involves intramedullary infusion of antibiotics. I don't think it's, I mean, I think it needs publication in peer-reviewed articles to convince me, as it should. But I do think one of the things that was underplayed in this, and speaking to some of the orthopedic surgeons locally, one underappreciated thing is that this guy Lautenbach did the intramedullary infusion, so really just sticking almost like an intraosseous drain into the bone, infuse antibiotics there. He did that, but he also did apparently very meticulous debridement of the bone. He was renowned for spending absolutely hours taking off every piece of dead bone in the osteomyelitis cases, and that combination worked well. My suspicion is it worked well because of his debridement rather than the intramedullary infusion. And I know it's very popular here, but I can't credit it, I'm afraid, without evidence personally. And as you rightly said, you know, we've got oral available therapies. You have good evidence that intravenous antibiotics will reach the bone in adequate concentrations. I did come across,
what I did see, and I mean, generally observational stuff was, again, these sort of local antibiotic strategies for the most part, antibiotics like impregnated cements, spaces, or even the infusion, the sort of infusion systems that irrigate the prosthetic joint. There's not a huge amount of evidence I could find for any of those local-based strategies, even though in theory it makes sense that there should be some effect. But it wasn't something I came across that had a fair evidence base. It was generally observation.
I agree with you. Generally, those local things haven't worked in any domain. You know, we've had antibiotic impregnated everything's over the years, and when they're done in RCTs, they fail. And they're often, I mean, not always, but depends on exactly what you're talking about. But in general, yeah. And again, I think, you know, if you, on the one hand, you're moving to oral antibiotics soon with the Oviva trial, and then on the other hand, you know, there's the intramedullary, and I think that the evidence is supporting the first, not the second. And then there's a question on that from Dr. Spence about, do you recommend greater interaction between ID clinicians and orthopods in the management of bone infections? And how should this be mitigated?
I watched a whole host of talks, and some of this talk was based on the Harvard course, and I watched a whole host of talks about osteomyelitis, generally American-based. And I've got to say, it really is, you get the impression it's something they've got right. It was stressed in almost every talk. It's stressed in most guidelines. That the truth is multidisciplinary approach. It's the same as like with endocarditis, where you sort of wish there was real buy-in from each role player in the treatment of the disease entity, and certainly a multidisciplinary team, as in the first slide. That here you need a microbiologist, you need an infectious disease clinician, you need a good orthopod who's happy to help, happy to biopsy, and willing to review and revise if needed further debridement. You need a plastic surgeon sometimes when you need coverage. So really a multidisciplinary team is, I think, key for these infections. And I think something that there's certainly room to grow on. At least I can speak for Bara. I think that there's really room to grow in that sphere.
Sure. I'm just looking through some of the other comments. Yeah, and then you did mention it, just worth reiterating to the audience as well, that holding off antibiotics is almost always the right move here, at least initially. Sorry, I mean until you have cultures. So osteomyelitis is a chronic infection the vast majority of the time, and the ones we see almost always. And it really doesn't pay to have to put someone on empiric therapy, which may be wrong, without a formal culture result. And it saves so much time and effort down the line if you manage to get that off. I mean, there clearly are always going to be exceptions. The people who are bacteremic or something like that clearly can't wait. But then you have your answer anyway, I guess. And the patients who are very hemodynamically unstable. But again, that's not typical at all of osteomyelitis. But people see osteomyelitis, they throw antibiotics and then call ID. And it's totally the other way around. Hold off, get a bone biopsy, or 2 or 3, as you said, depending on the scenario, or more sometimes, and then look at that all together and make the best possible decision. There's so few times that you need to guess. So, I mean, in the vertebral osteomyelitis, as you know, unless there's a bacteremia, they still say, we get your biopsy and then decide, and makes sense. You don't want to be treating suboptimally.
In the absence of bacteremia, in the absence of neurology or impending neurology, definitely the way to go. And even antibiotic, I mean, at times it's advocated to do antibiotic-free intervals if that has been done, to stop them, wait 2 weeks, and then go ahead and do the biopsy, especially if it was culture negative. That's also advocated in some of the literature.
Agreed. Oviva trial is fascinating and lovely, and I'm glad they did it, because it's a brilliant idea and it makes a lot of sense. And I hope we move more that way. I think that some of it, actually, the multidisciplinary nature of it is a downside to, because we certainly experience internationally is that many of the orthopedic surgeons don't like, quote, only oral antibiotics or something. But as we said, it doesn't make a lot of sense. You've got good evidence. In fact, if anything, the Oviva group did better, although they were technically non-inferior. But there's certainly no hint of them doing worse. One consideration, though, just one thing just to remember, is that they really didn't have almost any oral penicillins and no cephalosporins at all. And so most of them are quinolones and clindamycin and doxycycline, all of which are highly bioavailable. So the one over extrapolation you might make is that these can be extrapolated anyway. I think that the challenge is really going to be proving that the same applies to much less bioavailable drugs. Certainly in the supplementary appendix, if you look at the penicillins, they were the only group which the point estimate was worse, with a massively wide confidence interval because there were so few of them. But that kind of makes sense given the poor bioavailability. So that's the other thing about it. But I've got Evan saying OPAT therapy could very well make OPAT for osteomyelitis a threatened species, oral therapy, sorry. Agreed. I don't know if you want to add to that, Leo, but that'll be good in my view.
So what was the question?
Sorry,
oral therapy. Yes.
Oral therapy will make outpatient antibiotic therapy. So in other words, the OPAT given usually intravenously would make it obsolete.
Yeah, I mean, it makes sense. And again, I think that we've got good bioavailable antibiotics. The bone, in that one table, essentially the bone to serum ratio is higher for the vast majority of oral antibiotics, in fact. So I think that the Oviva trial really does make that the way to go, with the exception of, as you mentioned, maybe the penicillins, and the other consideration was where you've got drug resistant or difficult to treat organisms. I think that also would have to be an individualized scenario.
Sure. Yeah. I mean, I think you could do it as long as you're happy with the oral bioavailability of whatever you're using. So the beta-lactams in general are tricky with oral bioavailability, with some exceptions. But I agree with you. I mean, I think if you're using the sort of regimens they used in the trial, there's no reason to assume they wouldn't work. It's a really wonderful trial and well overdue in some ways, but fantastic that someone did them.